Hello, welcome to the Standing Committee on Health and Social Development. Today is Wednesday, October 21st, 2020. First thing, can I get a motion to adopt the agenda? Heath McDonald. And with us, committee members Tricia Altez, Heath McDonald, Corey Deagles here today, Sydney McEwen, and Hannah Bell. My name is Gordon McNeely, and I'm the chair. So today we're going to have a 15-minute briefing from Island Ems, and what I'll do is, and Dr. Scott Cameron, and what we'll do is we'll just pass it over to our guests, and they can introduce themselves, and then and Ola Hammerlin will be joining us as well. So then you can proceed with your presentation, and you'll have about 50 minutes, and then we'll ask some questions afterwards. So I'll pass it over to our guests. Thank you for coming.
Great, thank you very much. My name's Matt Crossman. I'm the president of Island Ems and work for Medivh. The colleague to my right is our medical director for emergency health services for the Department of Health in Prince Edward Island, Dr. Scott Cameron. We appreciate his presence here today and support as always. My colleague behind me is Darcy Clinton, who is our paramedic chief and general manager for Island Ems. And our other colleague to the right is John Ferguson, who works in some of our mobile integrated health programs, and we thought it would be a benefit to have him here today. So thank you for the opportunity to be here today and for the time to go through a quick presentation. We'll pass it back and forth amongst our colleagues, and if at any time you have a hard time to hear or need anything, please put up your hand and don't be shy. Thank you.
Thank you very much.
Island Ems is a subsidiary of Medivh. Medivh is a not-for-profit organization which has two divisions. One is Medivh Blue Cross, which I'm sure a lot of you are familiar with, is the insurance group, which looks at employer group benefits, individual benefits, and some government programs like MSI, as well as they do veteran affairs and other types of programs. Medivh Health Service is our medical health company, and we look at all kinds of different things such as ambulance operations, 811 and mobile integrated health, clinical training, and home health care, and I'll get into that in a little bit more detail. Our Medivh Health Foundation, which we're extremely proud of, is where our profits go from the Medivh Corporation. So Medivh being a not-for-profit, our profits either go to the Health Foundation or are reinvested back into the company in different areas such as infrastructure, IT, programs and development, etc. So our Medivh Health Foundation has three main branches. One is adolescent mental health, the second is healthy living, and the third is post-traumatic stress, as obviously a lot of our frontline providers are intimately involved in very detailed, orientated, and sometimes unpleasant situations. We wanted to make sure that our organization, as well as outside of our organization, has an area to be able to donate and look at that really important aspect, which is post-traumatic stress. Medivh Health Service as a company has paramedic services which you would be aware of, such as Island Ems, Ambulance New Brunswick, and Emergency Health Services in Nova Scotia. We also have ambulance operations in Ontario, Alberta, Saskatchewan. We also provide ambulance operations for the federal government in Indigenous Services Canada through Ontario, Manitoba, and Saskatchewan. As well as we do a lot of clinical training, not only for civilian, but also for the federal government. We do all the national defense paramedics for the Canadian Army, as well as provide 811 telehealth solutions, home care, which you would know as extramural in New Brunswick, and medical communication centers in 4 of our locations. We employ just over 4,300 healthcare professionals across 6 provinces, and have about approximately 1 million annual patient contacts. Here in Prince Edward Island, I've had the fortune to be Darcy, the previous general manager prior to my appointment to president, and we've had a great long-standing relationship with not only Health PEI, but the Department of Health and Wellness, and have really been able to innovate and provide additional service offerings over the last decade. A couple that you would be familiar with is the Collaborative Emergency Care Center, which is obviously in Western Prince Edward Island, as well as the program in 2015 where paramedics were providing palliative care, and more recently in 2018, which Dr. Cameron will talk about a little bit later, is our advancement in mobile integrated health. John?
Thanks, Matt, and thank you to everybody for the invitation. Today, I know the focus of the discussion today is to discuss experience with home care as it relates to Prince Edward Island. My job, or my role with Medivh kind of takes me across the country doing a number of various initiatives. Thought I'd just take a few seconds here. We won't go into any great details. Happy to take some questions later in the interests of time about some of the themes that we're just seeing across the country that I think would be pretty fair to see most people would, I think, have some firsthand experience with. And again, we could speak to lots more, but clearly in the age of COVID-19, a number of things have happened in the healthcare system that have caused people to reprioritize and redirect some of their efforts. Some that we're seeing, obviously, and we can speak to specific examples later, the changing healthcare needs, I think that's intuitively obvious, the shifting patterns and norms, looking at even an example there of virtual health, where in some places virtual health might have been 4% of the interactions with primary care providers. In some places it could be as high as 60 now. The emergency deregulation, I think everybody can see examples in the system where things maybe could have progressed over a number of years, but necessity is the mother of invention, and sometimes the deregulation or the ability to move forward has to be considered, and I think we could all think of examples there. Non-traditional players in some of this space, in particular around the adoption of digital technologies and digital health, and obviously the reprioritization of needs in general, as some examples. Some of the continued impacts, and I want to be clear here, this is us kind of sort of reading the tea leaves ourselves in terms of what we think is likely going to, happen over the next few years. And I think we would say that generally, we see the COVID-19 probably, we're probably not going back to the way we did business, right? There will be some change that will be permanent. Some of the areas where we think that that's going to likely happen is the addition of digital technology or digital adoption and the ability to use technology more to be able to do things in a maybe a cost-effective and a more efficient manner. The impact on health and human services is clearly going to be something, whether it's the demand for people in public health, some of the requirements around long-term care, how you're going to support aging in place. We really see this as something that's going to be a challenge for the next little while. And obviously using the digital technologies and the data, there will be an abundance of data. And some of the challenges may be just trying to make sense of what's important and what's not important. And I think last but not least, and this would be no shock to this group either, is that, I think we just see a continued need to support mental health as this goes on, whether that's financial, emotional, social isolation. I think this group would be well in tune with some of the drivers of this, but we know that we've seen some reports that would suggest Canadian reporting of high levels of anxiety has quadrupled since COVID has been introduced. So I think we just see that, whether that's in our workers and our clinical staff or just the general population supporting them. So with that, back to Matt, I believe.
John, as John just mentioned, the care in Prince Edward Island is extremely high quality level of care across the board, but obviously COVID and an aging population has created some challenges, not just here, but across the country. And when we look at aging in place, there's obviously wait lists, vulnerable patient populations, patient waiting for ALC transitions, COVID implications. All of these things add an extra complexity and also an extra need to be able to adapt within the system. And we need to look to be able to create capacity for system demand, not just daily, but also after hours, weekends, and other type of things. We need to be adaptable and flexible, and we need to be able to embrace digital capabilities and reporting where possible, and really work with one thing in mind, and that's to wrap services around patients and make sure that they get the care at the right time, at the right place, by the right provider, whoever that might be. Dr. Cameron?
So I'm here actually not as a member of Medivh, but as the medical director for the division of EHS within the Department of Health. We've been very involved with Medivh partners in mobile integrated health initiatives over the last several years. And mobile integrated health is something that really arose out of principles of community paramedicine, and the idea being that you could take the healthcare skills of paramedics and leverage them to non-traditional, non-lights and siren responses to meet needs in the community. And if you look across not only Canada but the world, we're seeing rapid burgeoning use of paramedics in a variety of roles and capacities. Here in the island, we have a paramedic check-in program. It's a seniors check-in program. One of the things we're doing is we're identifying patients who have high needs by virtue of frequent calls or frequent falls, who sometimes just need to be picked up and dusted off and set back on the sofa. And we're now having the paramedics kind of continuing to look in on those individuals from time to time, make sure they're all right, make sure they're eating, make sure they're taking their medications. We also have the first mobile integrated health program we had in the province was probably the Collaborative Emergency Center in Western Hospital, where they no longer had capacity or human resources to keep physicians in the department all night and still manage the workload in the daytime. An advanced care paramedic and an RN working overnight with direct telephone support by an online control physician through the communications center allowed care, decision-making, triaging of patients either to come back in the morning, to be referred directly elsewhere. So that's one of our first success stories with mobile integrated health. Subsequently, we introduced the Paramedics and Palliative Care program. We co-developed it with Nova Scotia. We've been in North America, we've been a world leader in that space, and we've arguably been the most successful jurisdiction in that space thus far. About 30 to 40% of the calls to palliative patients on social hours, the hours when they can't necessarily access other members of their care team, now are able to stay at home rather than be transported to hospital, meeting the needs of the family, meeting the needs of the patient, and arguably meeting some of the needs of the system as well. So that's been a real success. We're now developing working groups to do some rapid bridging programs to take some of those palliative patients and get them home more quickly if they are in hospital. And we're also looking at rapid bridging programs to help facilitate moving people back out of emergency departments into community care at home rather than moving them to inpatients. It's not the intent for the mobile integrated health paramedics to take over the work of home care. It's to provide a bridge, to provide that 24, 36, 48, maybe 72-hour buffer until home care is able to figure out how to pick up the capacity and care for those individuals at home. So this is all exciting stuff. When I look at things every day, I look at it through the lens of how can we integrate? And knowing some of the resources that Island EMS has, the comm center and what have you, there are incredible opportunities to continue to integrate care. We're looking down the road towards more directed pathways for people who call 811 to connect them directly with resources rather than have all the decision trees end with go to the emergency department. Maybe connect them more directly to mental health counseling or other services. We're hoping in future to be able to access some scheduling for some of the primary care services directly in a limited fashion, and maybe provide some of those callers with a single portal for those things rather than say you need to call your doctor in the morning. We hope at some point to be able to look online and say, we see that your primary care clinics have an opening at 10:45 tomorrow. Would that work for you? If so, we'll plug it in. So that's not there. We're not there yet. But those are some of the things when we think about integration that we need to start to think about how does the system work holistically together rather than in isolated silos. And I think that one of the things that the comm center that we have in partnership with Medivh offers is an opportunity and a nexus point to start to do some of that. We also have some other initiatives that we're just starting to roll out. We first used remote patient monitoring in an EMS context with one of the COVID-19 patients recently, just to ensure that they had some additional support and security at home to make sure that they were remaining healthy between check-ins. So we see a lot of room and scope for progressing that in future to a broader spectrum of patients. And I'll hand it back to Matt.
Dr. Cameron. As Dr. Cameron mentioned, we do have an investment already in our communication center, which deals with 911, 34 out of 36 fire departments, as well as our EMS dispatch. There's also a direct linkage to the health system. And as Dr. Cameron said, we've started to, through our mobile integrated health program, be able to leverage that to meet the needs of patients. We're also looking at other ways of how we might be able to monitor patients, as Dr. Cameron mentioned, remote patient monitoring or those type of bridging programs. The effort is really to get the right services to those patients, whether it's within Island EMS or externally, whether it's within Health PI or other agencies. It's breaking down some of those barriers and being able to get the right services to the right patient at the right time. John?
Thank you, Matt. Again, just making sure we leave time for your questions. One of my other initiatives a number of years ago was kind of leading an initiative in New Brunswick that was intended to basically leverage the full capabilities of a home care program and see what the art of the possible could be by further integrating it with the extramural program and the EMS service. Not here to suggest that that's focus of this province, but I think there are definitely some lessons learned there that could be adapted for Prince Edward Island as well. But in terms of looking at opportunities, what we would be looking to do through further integration and collaboration, I think, is a number of things. We'd be obviously looking to find areas where we can integrate and work together to improve the continuity of care of the patients. We would look to leverage both clinical assets, both on home care and other agencies and EMS, to optimize the scope so that we make sure that everybody's fully contributing to the system to the best of their professional practice allows. Looking at creating capacity and looking at how we can create efficiencies or drive economies of scale to create capacity. That capacity is intended to be then kind of offered up to the healthcare system to see how can we actually repurpose this. What do we do with the efficiency? And I'm not here to prescribe where it would go, but given all the challenges with aging in place, I think everybody would agree the healthcare system has lots of work ahead of it. But if we can create those synergies and create that capacity, how could we really repurpose it? And there really is an opportunity, I think, to do more work together and potentially create a more integrated out-of-hospital platform. Or as I would say, you have an integrated platform that can allow the system to support both the inputs, i.e. trying to keep people out of the hospital, and the outputs, trying to get people out of the hospital quicker, right? So I'm happy to take some questions on that later if there's any questions. Back to you, Matt.
Thanks, John. And just in summary, I think John did a good job kind of paraphrasing, but essentially what we're looking at is being able to expand mobile integrated health, being able to look at integration with the current programs in place, whether they be Health PEI, home care, primary care, other types of agencies, and really look at how do we, integrate these services, how do we break down any barriers that may exist, and how do we make improvements into the healthcare system. And then I think lastly is, just as Dr. Cameron mentioned, we do have an already invested communication center with linkages to the health system. How do we leverage that for the patient and get them access to care in a timely fashion and make sure that we have resources there to be able to kind of leverage those expertise and get the people to where they need to be. So with that, I'll open it up to any questions.
Thank you very much. Yeah, we'll open it up to the committee for questions. We'll start with Trish.
Thank you, Chair. And sorry, just to refresh my memory, Chair, we're going to limit questions, right? Just so I can.
Yeah, we'll limit questions to if you can pick up the pace with your questioning, and we'll limit questions to
So I know
three.
how much I got to narrow it down.
Yeah.
That's okay. Okay. So thank you so much for that presentation. I'm wondering if you could speak a little bit about staffing levels and whether or not, first of all, is it a challenge to recruit and retain staff in Island EMS or not?
Sure. I'll start that off and then maybe pass it to my colleague Darcy, who's the Chief and General Manager. Island EMS has had a long-standing history of being a great place to work, as a paramedic. We've been very fortunate in being able to leverage Holland College, who does provide paramedic training right here on the island. And we've actually actually had a really good staffing level of paramedics come through our system, not just now, but through over the last, decade. Obviously, there are, some challenges as we increase programs and have more and more positions, but we're always doing recruitment and we're always doing hiring as well, and putting, new paramedics through our programs or orientations. Darcy, do you?
Yeah, and Matt pretty much touched on all the points there, but as far as Hall and College is kind of our main bread and butter where we get our paramedics from, and they do a great job of supplying what we need. Obviously, COVID has put, I think, a strain probably on everybody in meeting some of those, but overall, no, I think staffing levels, and we are continuing to recruit. I just actually was speaking to the new recruits that we were just hiring just before I came down here, so we had 6 more that we were hiring today. So I think as we continue to recruit, and we always have good feeder systems in to kind of continue where we need to go, for sure.
Trish?
Thank you, Chair. And as you're taking on, new programs, for example, the, home care program, as you discussed, are you also increasing staffing capacity?
Yes, so as Darcy mentioned, we're always holding open recruitments. We have a fairly rigorous hiring process because we want to make sure we get paramedics who are very capable and very ready. And we also have a mentoring kind of program to make sure that they do go through the proper channels. But we're always holding open calls for paramedics. And as we kind of increase with new programs or new potential positions, then obviously we would up that intake to make sure that our levels are there. It does take a little bit of time, but as Darcy mentioned, Hall and College has done a great job at producing paramedics. And Island Ems is very fortunate to have a large number of advanced care paramedics in addition. So we actually have a very high level of quality care practitioner that we're able to leverage from.
I just have 2 more questions.
Yeah, go ahead.
So in terms of the, so that's great to hear. In terms of sort of the what most people would see as the primary role of paramedics, responding to emergencies and being available to respond to emergencies, do we have a sufficient supply in terms of vehicles and paramedics on the road to accommodate the needs in Prince Edward Island?
Sure. So again, I'll start off and then pass to my colleague. We're always looking at our response time rates, and we're always looking at our ability to respond to calls throughout the island. Prince Edward Island, has a great response rate and has over the last number of year or decades. We're always looking at that as the call volume continues to increase. With COVID, we've actually seen an increase in call volume, so we're making sure that our trucks are staffing. Originally, when COVID first hit, we did see a decrease in the amount of people calling 911. I think basically based on fear and not knowing exactly, not wanting to go to a hospital. But as you've started to see that level off, you're starting to see people call. As some of my colleagues, Dr. Cameron and John have mentioned, we're also looking for ways to make sure that we get people to the appropriate level of care. So not everyone that calls for an ambulance necessarily needs to go to emergency room, and part of that is developing those MIH programs or looking at other types of programs where we might be able to get them to an appointment at a later date, or other types of things that might be better suited to the patient. Darcy?
I think to answer the first question, yes, we do. I think the system that we have in place for paramedics, that everybody thinks we're always responding to 911 emergency calls. I think the biggest thing that we have to do is change the way we do business and the way that there's feeder system or other opportunities for paramedics to refer or use the communication center for us to do that. If I keep just adding ambulance and ambulance, I don't think it'll ever solve the problem. I think we need to find other solutions and pathways. I always think there'll be ambulances and there'll always be paramedics to respond to those emergencies. But our biggest thing is to try to find alternative ways that they're not always going to emerge, and we define different pathways for them to go to. Absolutely.
Follow-up question to that. Do you have any suggestions on what some of those alternate pathways or ideas might be?
And a lot of them they brought up in the communication center where we have 811. We currently have a paramedic that's now staffed since COVID for a clinical support desk where they're providing our COVID response teams and able to provide testing that way. But referrals and stuff like that, all these things that they suggest that there's things to able to do that for us to be able to treat somebody at home until home care can take over, all these things to keep people that have emerged, to avoid further 911 calls. No matter if we put an ambulance on every corner at some point in time, we're not going to have enough ambulances because there's just going to be that system. We need to find alternative ways and how do we treat them.
Another example, if I could just add to Darcy's, is we've looked at a program that we've just had recently for the last couple of years in Nova Scotia, where paramedics do respond to long-term care centers. And essentially for the last 3 years, 90% of those patients who would have otherwise been transported to hospital are being able to be treated in the long-term care center and not being transported to hospital. And that's been a big success because those patients, one, don't have to get in an ambulance to be transported, but then they're also not putting extra strain on the healthcare system. They're able to be treated and released there. So those are some of the type of programs that we're always looking at to see how can we get services. And you know, in other areas, as John mentioned, we're sometimes looking, maybe it's a home care practitioner who might be able to go visit the patient as opposed to having to go to, you know, see a physician in an emergency department. Or as Dr. Cameron mentioned, scheduling to see a primary care physician at a later time that's better suited for everyone.
Heath?
Just curious, I know you talked about the importance of mental health and what COVID basically is exposed in that, but I'm just wondering have the paramedics, are they part of, or your organization part of the crisis rapid response teams that are meeting to deal with situations?
Yeah, so with the new program that was recently launched, paramedics are not the primary contact in the program, but they are available as a tool as other practitioners would be available. So if the need arises where a paramedic would need to be responding, they would be able to contact our communication center and request them to be responding.
Heath?
So you're not a part of that group that's presently, okay, interesting. My next question was going to be about the training as far as mental health and paramedics to deal with, you know, issues that may arise when they have to be confronted by them. But obviously, I'll leave that one.
Thing is that, I mean, in terms of just the investment in our own staff, in terms of mental health, all the staff that are either trained as students or once they enter the workforce, they all generally get a educational session that we call Road to Mental Readiness, which is just talking about their ability to recognize, you know, that this is going to be a kind of a stressful workplace at times, and that they understand how to monitor their own ability to kind of process this, and if there's any issues, trying to give them some abilities, some more awareness about themselves and when to kind of ask for some more professional support. So we've spent a lot of time as a broader organization trying to prepare our people for this, and then now that COVID has you know, risen its head as well, we spend a lot of time in terms of putting supports in place for them as well.
Just to add to that very quickly, we also added, once COVID initiated, Mind Beacon, which is another area for our staff to access if they need more direct access to mental health practitioners, and that's been another added resource that they're able to, because we do recognize they're in very stressful situations.
Oh, excuse me, just sorry, Dr. Cameron.
I can add something, I can add something to the mental health crisis response. There was initially a lot of work done in development that would have seen paramedics as a principal responder with an allied health professional with specific mental health training. There were decisions made at Health PEI to go in a different direction, and that direction involves law enforcement, and at this time there is not a direct involvement of Health PEI or of Island EMS or the EMS services. I think we'll have to wait and see how that program evolves. I think that at some point in future it might be worthwhile to revisit it, depending on how things work out with the program as currently. I personally felt that it made more sense to use paramedics and a mental health worker than law enforcement. However,
Thank you. Last question?
And I think the superintendent who was here at one of our last committee meetings agrees with you wholeheartedly that the RCMP and City Police are not necessarily prepared to deal with those situations. So it's good to hear that, Dr. Cameron. But just I know I don't know if it was 2017 or 18 that I know the government of the day provided $500,000 or more to home care, to Medivh, to look at how you could improve home care and involve the paramedics, obviously. And I'm just wondering if you have any data on that, or if there's any information that you could share with us on the success or non-success. Obviously, it must be a success, but I'm just wondering if there's anything you can share on.
Yeah, great question, and then I'll throw it out to my colleagues as well. As Dr. Cameron mentioned, the Mobile Integrated Health Program was launched, and the Seniors Check-In was the very first program which was launched, specifically some of the vulnerable patient population or frequent users of the healthcare system. And we do actually have some data which we'd be able to share with the committee afterwards, but great success, lots of patient interactions, very positive feedback from the patients, and we believe the program's been very successful. Dr. Cameron?
That program has been very successful, and I think the COVID response has slowed some of the other program development as people have refocused on trying to. So we're now actually trying to bring the working groups back together to flesh out the policy parameters around rapid bridging. We have been using the mobile integrated health paramedic capacity to do mobile testing of COVID, and at one point we're involved in doing some of the screening at the request of the CPHO for the ferry traffic down in Surrey as we tried to scramble and meet all of the various bits and pieces. So it's not that the mobile integrated health team has been underutilized. We've been simply deploying them to put out the grass fires at the moment, and we're trying to get some focus back on what were some of our original program intents around MIH.
If I could just can we top up? And Matt, maybe you could just think through the palliative care example as well, but I think we do have some perspective on the successes of palliative care too, I guess. I mean, you have the numbers probably better than me.
Yeah, so just previously mentioned, we've been able to reduce, upwards to 40% of patients who otherwise wouldn't have been able to get care by being able to provide care in the home, which has been really successful. Just in Prince Edward Island alone over the last year, it's equated to a large amount of, patients that would have otherwise had to go to some other type of service, whether it be the hospital system or an extra demand on home care. So it's been really great to see those successes.
Hannah?
Thank you, Chair. Something you'd mentioned in your presentation was a couple of things around data and digital adoption as sort of, opportunity and challenge. I'm hearing some really good things from you in terms of you seem to have a really good handle on the data that's coming through the programs that you're providing. What we hear from other aspects of healthcare is often that the siloed nature of our kind of program delivery can create real bottlenecks. Like, we know that we can get them into this space, we can deliver. Has that been something that you've experienced, as particularly in this transition to, where you're trying to provide this sort of extra support or changes in support delivery?
Yeah. Sorry, Dr.
You're both nodding at me, so I'm thinking that's resonating, yeah.
I can speak a bit to that. I was involved in some of the early development of MIH, and I think, we're all comfortable with what we do all the time, and when people introduce new concepts into organizations, there's sometimes resistance in various areas. We did initially, I think, have some resistance from some of the existing organizations and unions about what does this mean, are we privatizing, are we bringing in, and we kept trying to come back to publicly funded, privately delivered in this case, but integrated. And we don't, there's an awful lot of room in the sandbox for everybody to play. So I think that some of the components of the system that may have felt a bit threatened at first have started to gain a lot of comfort that there is a partnership role here. And I think that the important thing to think about always is integration. So when we say mobile integrated, we're really thinking about how do we integrate. And I think that some of that is going to come back, excuse me, at the end of the day, to really starting to understand how to leverage our communications center to make sure that we're using the right resource at the right time. Not all EMS responses have to be lights and siren, and not all destinations have to be an emergency department, but we have to build the structure and the policy and the capacity in the other areas to accommodate those things. So there's all kinds of ongoing discussions, but I think that the system is slowly opening up to the idea that we need to break down some of those barriers. At least I hope it is.
Perfect. Hannah?
Thank you, yeah, and like I said, the nods kind of told me it's, you know, like there are challenges there. I mean, when you talk about creating capacity, like you said, if you've got a really great model that's working sort of at that point of entry, the barrier may be getting to the point of entry, you know, whether it's through sort of referral, you know, I'm thinking of even just the transition of a paper-based sign-off process into, you know, a very well-based digital communication center. The gap sits in that space in the referral. From a constituency basis, the challenge I often find is that it's how do I get people into the place where they can begin to access that service versus the experience they have with it, which is great. And so you know, one of the things we've talked a lot about is just about roles from a healthcare perspective, and I think you spoke to Dr. Cameron, is the reluctance to change is one piece of that, but also are we providing the supports and investments in the behind the scenes stuff as well. So where you have, you know, a financial commitment to the private delivery of public health care in this bucket, what else needs to be supported to wrap around that so that we can feed appropriately in, and that we're collecting the information both ways. You know, like you may have great data, but if we don't have the outcomes measured in the other end, so that there's quite a lot in there, but I'm just saying, what else should we be doing to support, to make those transitions more effective? Because those are the bottlenecks that I see.
I think Dr. Cameron touched on it a little bit with just the startup of his committee again to get all of the players together. One thing from our organization is, you know, essentially there's no right or wrong door, right? If information comes out, it's about getting it to the right provider, and that may be within our walls. It also could be within Health PI or some other organization. It's about getting those services to the patient. Dr. Cameron's group has been able to get together and really break down some of those silos to figure out how do we get that information. With the launch of mobile integrated health, as he mentioned, in our communication center, we've been able to direct pipeline into the healthcare system and figure out how do we share information, how do we get people access to information, and how do we do what's right for the patient. So obviously it's a work in progress, but a great first step, really.
Supplemental to that, everybody's got an IT project on the go most of the time, every department. I think one of the things that's needed is a high-level policy direction that says they have to talk to each other. There's no place anymore for non-cloud-based, non-multiple access point solutions for information to be shared. And every time we see some part of the health system create a standalone electronic system that doesn't talk to some other part of the system, it's one of the visions that I have in the intermediate term for the communication center is to actually put a physical person in there to actually do some of that data transfer between the various bits and pieces that aren't talking. But in the long run, that work should be automated. There shouldn't be, in 2020, anybody developing something that can't talk to the existing systems. And unfortunately, we're still seeing examples of that occurring. So that we have home care and some parts of mental health and addictions on one digital platform, which does not communicate with CIS, which is where all the acute care stuff is. We've had delays, we have the paramedics doing digital documentation, and we've had delays in being able to integrate that into CIS. And I realize that there are IT staff capacity issues which are part of the issue, but I think sometimes there's just not enough high-level impetus to make it so. And the tools are there. In a lot of cases, we simply haven't turned them on.
Thanks for the answer. We're 5 minutes over, so we're going to allow another 5 minutes, and that would be it. So just putting that to the committee. So.
No, that's great. Thank you. That's really useful. So I appreciate your candor.
Thanks, Corey.
Thank you, Chair. At any given time, what's the amount of paramedics that are off on stress leave or with PTSD?
It would be varying throughout any organization, but at any given time, there could be one or two individuals who are either seeking counseling or, taking some personal time, but there also could be zero as well. So it would really be dependent on what type of incidents they've responded to. Or we also try and make sure that we do give our staff time to, debrief or take some time if they need that.
Corey? Oh, sorry.
Yeah.
Absolutely.
That is that when the first legislation came into place, it was definitely a little slower at first, but I find that we're able to get to people a lot quicker for help, and we're able to get them to return. And we have some good return to work success stories since that time, so it's been good that we're able to get them back to work as well.
Corey?
And what help is offered to them?
For them. On the ground level, I mean, we have our CISM support teams as well for the beginning, and then we also have road to mental health to prepare them so that, but, difficult calls, we reach out automatically. We have our EAP program, we have clinical psychologists that we use and reference, and through their providers as well too. But we have a lot of systems in place. The biggest thing is trying to recognize that they may have something before it becomes an issue, and reaching out to them and providing time off if they do have a bad call, providing the next day off, or giving them a break after that call has happened. Is some of the key things to kind of help. The culture change was a big thing.
Corey?
And do you have any of the stats on what the response times are?
We release them orally.
Are they going up or is it going down? There was a story back in the summer that they were increasing, but that also the volume of calls had increased.
It's just like anything, depends on the time of year, summertime obviously, and they go up and down, and it depends on the area, and it depends on the fluctuation, yeah.
Additional resources were added as well, Corey. Darcy can speak, but there were an additional, was it 60 hours?
Weekend coverage.
Weekend coverage added to the system because we were seeing an increase in the amount of call volume on weekends. Previous to that, there was mostly through Monday to Friday, but we had started to see a spike on weekends as well. So we did increase our additional coverage to offset that.
Final question, comment?
Final question. I guess I had a couple more, but one of the biggest complaints I get from the fire department in my area is that their majority of their calls now are for medical, and they just feel like perhaps the response isn't sufficient, but that's also a government issue as well. So I did have a question about the collaborative, the emergency care up west. Does that work well? Is that?
Very well. It's one of the easiest things that's operated, and paramedics love working it. They love collaborating with it. I think even as a community, I think if you talk to the community likes it. Absolutely.
Is that good?
Yeah, I just wanted to say that it'd be nice. I don't know if that model could work in Montague or not, that we could have a 24-hour emergency room open or not. But I think people are always hesitant. They think that it has to be a doctor there, but I think. Is it advanced care paramedics that do staff that?
I can speak to that. I mean, it is not a substitute for an emergency room. What it does is it provides a bit of a safety net so that if somebody is uncertain of the level of care they need, they can get an assessment by a nurse and an advanced care paramedic. In many cases, it's not emergent required care, and the care is deferred until morning, and then the patient is advised to return. There are cases where, they'll talk, and every encounter results in a call to the online control physician, regardless of the time of the day or night. Some of them may be some temporizing treatment overnight on order from the physician, and in many cases it is transferred to Prince County. So there are a variety of responses. It really doesn't, it isn't an emergency room, but it is a point of contact, and it really provides a triage function.
Thanks. Michelle?
Great, thank you, Chair. So first of all, I'd like to start off and just let you know, I recently have used your aging service, and there was a truck at my house on Saturday and that took amazing care of my dad, and I would like for you to please express my sincere gratitude to that truck and to the people that were on that truck. So one thing that I did realize, and now I understand lived experience is so critical, and we've talked about, where your bottlenecks are. We've talked about, the mental health of paramedics and that kind of thing, and how many people are on. One thing I did realize while we were waiting for a bed in emergency, there was 5 patients, 10 paramedics, 5 trucks sitting there waiting. That could have been helping other people, but obviously there was a bottleneck in the emergency room that day in order to get those folks that you were treating an actual bed. Can you talk a little bit about what you experience, and is that a regular occurrence that you experience?
Sure. First, I'll start out, and then maybe I'll pass to Darcy and then Dr. Cameron. Obviously, Dr. Cameron would have some direct experience. First, I'd like to say, thank you. I will pass that along, and sorry that you did have to use our service, but we appreciate the feedback. Yes, it is something we do experience. Darcy can speak to it a little bit more intimately, but it's not unfortunately, it's not a focus on just Prince Edward Island. We're starting to see this trend across the country. That's why I think it's so important to have programs that do keep people away from the emergency department, because you start to work on reducing that demand, and then also, as John mentioned, getting people out of the hospital quicker also will help reduce some of those demands. So some of the programs we talked today, I think, would make a big difference. But Darcy?
Yeah, so when I talk to my colleagues across Canada, it's not, we're not alone. It definitely happens. Does it happen here? Yes. QEH would definitely be probably the area that happens the most. And when situations like that happen, we do work with the team lead and the emerge manager there to try to clear up our trucks as fast as we can. We understand. I mean, we're part of the big system, so we know that they're trying to do their best to clear our trucks, and we need to kind of get them out. Unfortunately, it does happen. I hope for it to be less than that it does, but it does happen. Scott, I mean, you were part of it in your PCH. What's on this?
We refer to that situation as offload delay, and it is unfortunately becoming a fact of life. I work in Prince County and have for close to 30 years, and it's becoming a more regular feature of our lives as well. It's one of the reasons we're doing MIH, is to try and move some of the care back upstream and try and hold it in the community. But the solutions to offload delay are not in the emergency department. They are a reflection of capacity issues in a variety of other areas, and probably beyond the scope of this discussion today. But emergency departments clog up, so to speak, because they are unable to decant to inpatient beds the patients that need to be admitted. And they're unable to decant to inpatient beds because those beds have been unable to decant either back to the community or to long-term care or to some other alternate level of care. So you can see that it backs up. So the focus is often placed on the emergency department, and where you see it is you see it with the paramedics lined up in the hallway. But in fact, the source of the issue is unfortunately the 83-year-old lady who broke her hip and can no longer go home, who's been in a bed in an inpatient medical ward for 11 weeks, waiting for some alternative form of care that isn't readily available. So it is a challenge. I mean, I did some work in Dartmouth General a few years ago and watched a couple of crews actually do shift change twice during the time that I was there while still in the hallway. Nobody wants that. The physicians don't want that. The nurses don't want that. Clearly the paramedics, and nor does the patient who's been on that bloody stretcher for 13 hours want it. But I mean, it's happening everywhere. But the issue is not truly in the emergency department. I was working on the weekend and had to actually divert from our department because we had literally run out of capacity to look after anybody else in the department who of a critical nature. And that's horrifying for us. You know, I mean, we're terrified about that. When we see that, I'm looking, but if I get a heart attack now, I don't know where I'm seeing them. So that's a reality.
So we have Michelle's one question, Ola has one question. You have 10 seconds to ask your question. You have 20 seconds to answer.
That's fair.
Yeah, good.
So I will say thank you, because you afforded on the weekend much more time and,
coddling of the patients that you dealt with and we're seeing here in this committee today. So obviously, I think folks, that there's a much bigger discussion to be had here with affording much more time. And I know that was 10 seconds, so I'm going to take another 10 seconds because I'm just going to jump off of what Corey said about firefighters kind of being first responders. And a conversation that I had this summer was of the number of trucks that have to go off island with patients. And what that does is it diverts trucks from other areas. So for instance, maybe Tyne Valley is, and this was an extreme, Tyne Valley truck reporting to an accident or something that happened in Wood Islands. So obviously the firefighters, first responders, are going to be the first ones that respond to that because they're so much closer. Is that also an issue that you see? Because if you're trying to respond to accidents, you have pulmonary care folks that are going off island, that home care piece is kind of behind all of that, right? So when you're trying to create that space, what are some of the challenges that you have there?
Sure, I'll just answer very quickly. Our off-island volume is actually stayed very stable, and I think that's part of the great work at the healthcare system with Health PI, that they've been able to treat a lot of patients on island. There are some patients who do need a little more definitive care, and we do approximately 5 to 7 trips a day off island to either Halifax or St. John or some of those other areas. But we have been able to add additional resources, as Darcy mentioned about the additional hours. We've also added the rapid response units, which were additional units into the system to be able to do the mobile integrated healthcare stuff. And we're always looking to add additional bodies and individuals. We've also added 2 patient transfer units who deal with on-island transfers, and that's been able to suppress some of the workload as well. So some of the fire departments, it's based on what they decide to respond to, and it's based on the medical first responders. So sorry, Mr. Chair, I know
That's
it was
okay.
a little it's hard.
Good answer. Ola?
Thank you, Chair. Recently in my building, a person had a bit of a mental breakdown that involved yelling loud and locking his door, and the police responded. At some point, there were 6 armed policemen there, 2 of them in bulletproof vests, and I felt very lucky that no shots were fired. But wouldn't it be a lot more appropriate for EMS? Would they be capable of dealing with somebody with a breakdown?
I can speak to that. That was the model that we, as a working group, recommended, but I think there were some other considerations that I wasn't party to. But I agree. I think in this day and age, to develop a program, being very frank here, to develop a program for emergency mental health response that uses police services is rather tone deaf in the current environment.
So we'll leave it there. And I'd like to thank our guests. And we don't have time for this, but Matthew, I might say to you, what I would have asked is that if there was 1 or 2 things that you could present to the standing committee when we make a recommendation to the legislature that you would like to see their provincial government do on behalf of your organization, could you put that in writing perhaps, and
Sure.
then we will make sure that gets put in the report.
Absolutely, and thank you for your time, Mr. Chair and committee. We really appreciate it, and sorry for going over.
Oh, we might have you back at another time because this was very beneficial. So thank you very much. We'll take a short recess and bring our next group in. We're back. So we're going to talk about PEI seniors' homes, and I'll pass it over to our guests, and they can introduce themselves and begin with their presentation, and we'll ask questions afterwards.
Sure.
Thank you very much.
Well, actually, we're going to talk about the long-term care society. PEI Seniors Homes happens to be the name of my company, but that's not who I'm representing today. I'm Bob Nutbrown. I own Garden Home in Whisperwood, and I'm president of the Nursing Home Association. At one point in time in my life, like my colleague, I was a civil servant. I was Assistant Deputy Minister of Agriculture and eventually Secretary to the Cabinet. Wayne, you may want to introduce yourself.
Wayne McMillan. I'm the Executive Director of the Nursing Home Association, and I'm here to support Bob in his presentation and answer any questions you might have.
Okay, Mr. Chairman, if I start with my presentation. I'd like to start by thanking the committee for their invitation. During my 15 years as an owner of long-term care, this is my first recollection of our association being invited to the committee. The members on my side of the table each have a high regard for the importance of a legislative committee as an opportunity for dialogue between the private and public sectors, each of us being in positions of senior civil servants within various governments. There was to be a third person with us, Ramsay Duff from MacLeod Group. He couldn't make it. His mother-in-law went into the hospital in the middle of the night, and he's begged off, obviously. Ramsay's a former Deputy Minister of Finance in Nova Scotia. I would suggest that I start my presentation by describing the implications of COVID for our industry. Overall, we've had tremendous cooperation with the government, with early action and agreements with the association that have kept our homes COVID-free to date. In response, we have hired extra cleaning staff, greeters for visitors, and made assurances that we have the staff to care for our residents. We have taken steps and advice from professionals to ensure that our buildings are clear of infection as possible. Our activity staff have provided as many positive experiences as we can, and while there was no substitute for visitation, we ensured that our residents did not go without interaction with somebody. We stepped up our Skype programming and encouraged as many window visits as we could. When visitations took place, we took many steps and extra staff to ensure the safety of our residents. We would be remiss if we didn't recognize the importance of the ministry and the Chief Public Health Officer, and our congratulations must be given to that system for preventing any community spread. We are fortunate that we have different than most parts of Canada because we are able to contain our population within our island and control visits from outside our jurisdiction. Just as an aside, I spent part of my life in Brampton, Ontario, which is part of the Peel region, which is a hotspot and a place that I wouldn't return to and haven't since February, even though I do some business in Ontario. Another difference is the differences between long-term care providers and PEI in other parts of Canada. None of the long-term care homes in PEI have 4-bed wards. While we never have had to use this very important agreement that we had with the government, we were able to send anyone diagnosed with COVID immediately out of our homes to either the government or the home in Montague that's been established. The Department of Health is to be congratulated for agreeing with this plan. As you know, in other provinces, that's been a major problem when people are with COVID, spreading it within the community. Many long-term care facilities closed their visitation rights before being asked to, and long before in any other provinces. We were grateful to our residents and our families for their patience during that time. The government worked closely with us and communicated with us through virtual town hall meetings and many emails. It was especially gratifying to have the minister and deputy involved in those calls. One possible improvement to the government's reaction would be to take account all the extra costs associated with COVID, including training costs and the allocation of double rooms becoming single rooms for isolation purposes. We have already been compensated for the staffing and the PPEs, for which we are grateful. I'm sure that there will be questions from the committee on this topic, so I would like to move to a more general discussion on problems faced in PEI by long-term care facilities. When I get into problems, I always need a drink, usually of water. For example, private homes are inspected on a yearly basis, and we're very supportive of that. We think that's great. The public homes operate under accreditation schedule, and this is a much more lenient interpretation of the standards. Our temporary deficiencies may be made public and gives the wrong impression to the public of the comparison between private and public homes. The private sector is also forced to charge more for private rooms generally than the public sector, and we have always asked that those charges are brought more in line to be fair to all citizens. The private sector receives a totally different payment than is expended by the public sector on a per diem basis. There is no difference in quality of care, but the private sector provides the same service and saves the province of PEI approximately $20 million per year in the delivery of the same service. We are not in any sense asking for equality of payments, as we appreciate that the government has treated us generally with respect and acknowledges our contribution to the senior citizens of PEI. As president of the association, I am a member of the Canadian Alliance of Long-Term Care, and am in agreement with the points raised by this association in many recent meetings with members of Parliament. I will briefly outline those to you. Number one, we're encouraging a higher transfer of healthcare dollars to the provincial governments. Originally, the federal government was paying 50% of healthcare costs for the provinces when the Medicare was established. It has now dropped down to 1/3. We recognize that healthcare delivery could be insatiable, but we believe that this transfer is extremely important to provinces with less of a tax base than other provinces. Secondly, the infrastructure program outlined by the federal government in the last few years has hitherto been unavailable to the long-term care. We would ask the provincial government to promote an allocation from the federal government to all homes in a manner that is appropriate with the local situation. Number three, staffing has become a Canada-wide problem, and PEI is not immune. The cost of hiring and training have become an important part of our expenditures. Immigration has become part of the solution for this problem. While all of our homes have promoted local employment, there is insufficient interest at the local level in this industry. We encourage the government to take steps to increase local interest from workers, and at the same time to promote the necessary immigration to ensure that our residents are cared for. Every province in Canada is using immigrant labor to fulfill their needs and have to be competitive, and this requires cooperation between the federal and the provincial levels. The Atlantic Province's Special Immigration Project has been helpful, and we would like to see it expanded for healthcare in particular. Having the proper data to make decisions in long-term care is essential. PEI is the last province to involve the long-term care industry in this data measurement. There are a number of companies that provide the service, and some private companies on PEI are pursuing the benefits of computerized management. We would hope that the government would make this available to all long-term care homes in the province. We see it as another step in enhancing the care of our residents. The above presentation is only some of our concerns and improvements that could be made in long-term care. Acknowledging the reality of our time allocation, we now turn the meeting and will respond to questions.
Great, thank you. Great presentation. This time, is there any committee members with questions? Hannah?
Thank you. Thanks very much. Nice to see you today. So there's a lot to unpack in here, but there's a couple of things I'd like to focus on. One of them is around the infrastructure support. There has been some creativity more recently with funding through CMHC and a couple of the kind of infrastructure relief programs where nonprofits and like, so I think schools was the one that was covered most recently, which is why we've seen, 3 schools suddenly getting accelerated. So is that the kind of thing that you're talking about? So targeted funds that could be used?
No, that could be used by us, but not generally. CMHC has kind of been in and out of the nursing home business for some time. Prior to coming here, I had a real estate business in Ontario. I had 300 agents. My practice was only nursing homes and retirement homes. And CMHC backed out years ago, and now they're back in. But I'm thinking more of the infrastructure announcements by the Prime Minister that would be available. There is one irony, and that's that the financial, I've talked to Heath about this actually years ago, Heath, you may remember, that the long-term care industry is not eligible for money under the local lending facilities. And I understand, I can understand the argument, but I could also argue the side that we should be. But I think that the important thing for us to ask for is for renovations more than building. We're going to have to build some new homes eventually, and that money would be available for that. But generally, I think most homes on PEI would benefit from some renovations. For example, I would like to, in my company, build 5 or 6 single rooms for isolation purposes if another COVID type were attacked by another COVID type pandemic. Nursing homes weren't built for pandemics. No. And so we may have to make adjustments, but we don't have to make millions and millions of dollars of adjustments.
Anna?
Thank you, and I appreciate that qualification because that we know there's a lot of talk about the build, right? But the adaptation of your business, renovation for energy efficiency or yes. for different changing needs. So so you're saying that there's potentially the space for federal dollars to be able to be opened up to so that you could access those, but also challenges with provincial lending programs as well. Is that?
Yes, I think we should be able to work something out there. It's kind of an interesting situation we're in. We're funded by the provincial government. We're inspected by the provincial government. We're licensed by the provincial government. So I say it's kind of a matrix of events that you have to try to put together and try to figure out and work together. And we're, at this point in time, we're a very collaborative group of long-term care facilities. I'm not sure that's always the case, but it is generally at this point in time.
Anna?
Thank you. I think the other factor that's in there, something you've spoken to in terms of some of your challenges, is that, you're experiencing challenges with labour shortage and the need for that kind of digitisation, but that's also the opportunity. You're an employer, a significant employer. You have a major impact in the economy in terms of sort of that aspect. And the other piece that's really important is about what you're providing, that it is not having to be provided directly by government. So there's a really strong argument to be made for supporting, more actively supporting the sector overall, right?
In my youth, distant youth, when I was advising governments, I said you have to stop looking at healthcare as an expense. You should look at it as a opportunity. And you're absolutely right. I mean, I'm constantly looking to branch out. And, there are people on Prince Edward Island. We've got a biohealth industry. We've got a drug industry, a small drug industry. And we've got some companies that do information technology. Lots of opportunities in senior care in that area. And I think it's a matter of bringing those of us that are experienced with seniors care together with those people and creating some new economic opportunities.
Thank you. Thank you, Chair.
Great. Ola?
Thank you, Chair. I was wondering what kind of waiting lines do you have for people waiting to get into units in the private sector?
The government tells us that there are 100 people in line. We're not sure. Sometimes a line is funny. Sometimes people are in a line and they're in 3 or 4 places, and then they get measured 3 or 4 times in that line. But we wouldn't be surprised if that's about the number. The number in Ontario is like 35,000 people.
Sorry. My bad. Go ahead. Continue.
Okay. So that's kind of in terms of the nursing home. In terms of community care, we don't speak for community care. They have their own association. But we all are members of the Community Care Association, except for one home. Atlantic Baptist is not a member, but because they don't have community care beds, but we have. The rest of us have. And we know that there are, as was announced today or yesterday, I guess, the market is not that high. That's an expense for a lot of people to go in. There is a subsidy, but it's not used as much in this area as, say, my home in West Prince, where it's fully subsidized. The residents are fully subsidized. I've often thought that maybe, just maybe, we should recognize that you're not paying long-term care. You're buying a service from them, the government is. And in fact, the money maybe should go to the seniors and they pick their service. But anyway, I'm not sure all of my colleagues would agree with that, but you got to realize that the money is really for the seniors more than the long-term care facilities. The long-term care facilities are to provide this service. Wayne, anytime you want to add anything to my more than lengthy answers, go ahead.
Very good. Yeah, perfect. Ola?
I understand that that your limitation is that the government doesn't give you license or support for any more units, but if the government was willing to, would you have the capacity to increase as needed? Would you be able to expand?
Well, under Robert Mitchell, who, by the way, was a fine minister of health, under him, they put out 100 beds. The Liberal Party put out 100 beds. And they were taken up by our people. Some people had to build. Some people could renovate. Some people would renovate community care facilities and turn them into nursing beds and that sort of thing. There would probably have to be some building, quite honestly, but some of us may convert some beds. Some of us may plan on building something anyway for community care and nursing homes. But we would find a way to do it, but it might take up to a year, to tell you the truth.
Thank you, Chair.
Great. Recently, we've seen the issue at Unit 9 where it was, the purpose of it has been changed, and now there was dementia patients in that area. So to me, that speaks to both mental health, but it also speaks to the dementia crisis that we have and the Alzheimer's crisis that we have in Prince Edward Island and the shortage of beds in that specific area. This affects a lot of families. Can you talk about the importance of that and what we need to do a better job with these people?
Some of the companies, some I know very well, have written to the minister and offered 16 to 20 beds in their facility that they would convert and help with the dementia and create a safety unit. Some already have safety units, but they're pretty full. Dementia is our #1 problem in healthcare and long-term care. And it's interesting because Wayne is involved kind of sideways in the home care industry. But I would say this about home care. I know there's a lot of interest in that, and there should be. But when you provide home care at a great deal of intensity, by the time the people decide that they can't look after their family member anymore, they're heavier care when they come into the nursing home. And therefore, the nursing home has to provide for heavier care and for particularly for dementia, because that is the problem that most faces families, and it's a disaster for families. I have 3 very good friends, you all would know them, and they've lost their wives over the last year and a half to dementia. And they meet every Saturday morning to kind of commiserate with each other about not only having lost their wives, but the time that they went through trying to care for them. It's a big problem, and it's a fine line. When do you send somebody to a long-term care home, and when do you give them home care? And but it is a big problem that the nursing home industry is getting prepared to deal with.
So with this situation, I know the minister is talking about having a solution by the end of the month to move those. Have you been in contact with him about potential solutions? Like what happens in this crisis situation with COVID probably creative, but now we're in this situation.
The minister sent out a request about nearly 2 weeks ago, I'd say, asking how many empty beds there are in nursing homes. And people responded. Ironically, there are not a lot of empty beds, and not a lot of empty beds that are secure. And so I don't want to speak for my company, but we did offer 16 beds up that we felt could satisfy the problem, and I'm sure other homes did. I just don't know that yet, but I'm sure they did. And there's seems to be about 20 to 25 in there. You know, I'll just speak about mental health for just a second. Mental health is going to be, amongst seniors even, it's going to be a very serious problem. It is amongst youth. I have within my family one problem, and it's almost a sickness across the province, where young people so anxiety-ridden that I mean, I know I'm here to speak about seniors, but I'm very concerned about the mental health problem, and maybe the private sector should be encouraged to get into that a little more.
I think you're right. Earlier this year, Minister Elward announced a full review of long-term care homes on PEI, and that compensation for long-term care workers would be a component of the review. Do you agree that this needs to be included in the greater review, the compensation for staff?
Absolutely. I had a call, if you can imagine, from British Columbia asking me if I could send them some workers. That's how bad the problem is across Canada. The salaries that we pay are not quite as illustrated federally. We're in much better position than that. But we know that we have to pay more to get people in. One of the problems that we face right now, and Wayne and I will be pleading for this at some point in time, is to get to negotiations between the long-term care industry and the government. Our contract was up April the 1st, and we think that those meetings, those negotiations will revolve around payments to our workers. We can only do what the government gives us, and if they will increase it enough, it'll go to long-term care workers. Let me just say quickly that long-term care workers are amazing people. We hire on character, and we train them, and we have people there 25 and 30 years that do their job. But it's not for everybody, and they come and go. We have turnover rates. But it's important that they be fairly paid. We do something in our company that I encourage other companies to do. We buy back sick days. So for example, if you have a year's sick days built up in the company, and then you build up another 5 or 10, we'll buy them back from you at the end of the year, and gives extra money to our workers. Many of our workers are single parent ladies who need the money, so we have to do that.
I'll pass it on to Michelle.
Okay.
Just a really quick question, actually. You just kind of triggered a question in something that you just said.
It's one of my problems.
But when Gord had asked about Unit 9 and the patients and whether the minister had reached out to see if how many beds could be available, and you'd said you were able to make 16 available, others probably said the same thing. The last group that we just had, though, they were talking about the bottleneck of getting patients out, like making beds available and having that flow through as people having beds at the other end. Can you just explain to me just a little bit about maybe what's the difference between, I guess it's the type of beds maybe that are available, or what's the difference there?
That could be a factor. They may not be secure beds at this moment, but for example, it may only take 2 doors, one at either end of a hallway, to make them secure. The rooms are fine. The difference is they're not licensed, and they would have to be licensed by the licensing board in order for us to be able to provide licensed beds at that point in time. We actually have 4 beds that were just licensed during the pandemic in our Whisperwood Villa home. And we did that to help clear the hospital. And other people have done different things, but that's the difference would be they're not licensed at this point in time to take people.
Michelle?
And when you say not licensed, I'm sorry, I think I need clarity on that. Could, for example, the example that was given to us is if somebody had broken their leg and they were in a hospital bed for 11 weeks holding a bed, and because there's no place for them to go, like a safe place for them to go. So is that what you mean by licensed, or are you talking about dementia?
No, I'm talking health conditions or dementia conditions or anything. If somebody broke their leg and has nowhere to go, the government has about 12 beds, I believe, at Prince Edward Home for restorative care. We think the private sector should do more restorative care too, and we've proposed that. But that would be more restorative care, would be a different kind of, there would be more occupational and physiotherapy involved and that sort of thing. It would be a different cost structure than we have.
Heath? Oh, was it?
You guys.
Oh, I didn't see you on the list.
Yeah.
Go ahead, Trish.
Yeah, oh, thank you. And I wanted to just clarify something. So did the minister reach out to your colleagues to find out if they could create 16 to 20 safety or safe units? No, the opposite. So your colleagues proposed that.
Yeah, it was on the news last night.
Mm-hmm.
So I watch Compass every night, so, but I phoned, in this particular case, I phoned my CEO, Jason Lee, and told him to get a letter into the minister offering those 16 beds. But the minister did reach out a while ago to see if there were any empty beds. And I assume it was for that reason. I'm not sure why, but I assume that was for that reason.
Trish?
Okay, and of course, it's not the patients that are currently in Unit 9 that have dementia. They can't be housed in just any bed. It is, you said, it's safe units, and that's part of the problem here is that the structure of Unit 9 is a safe space for patients with these particular challenges. So there would need to be some investment in making sure that we had a space that was suitable for them to move to, and that's sort of where the part of the challenge has been. Now, it is interesting to hear that a proposal did come forward from one or more.
Yeah, there may have been other companies that did the same thing. I don't know.
And just a rough estimate of, what might be the timelines or costs to convert, approximately, sort of.
It's not the rooms are not a problem. It's the possibility of wandering and wandering into the rest of your nursing home. And if they're violent, harming somebody, and it's the extra staff. You'd need some extra staffing, and you'd need doors that are pretty secure and pretty, and for us, that might be under $10,000.
Trish?
Yeah, no, and it is encouraging to hear that private homes have been interested in being part of the solution to solve this problem, particularly with the immediate need to restore Unit 9, in this case, to its intended purpose. But moving on from that, you in your presentation you mentioned additional costs associated with COVID-19 for staffing, and that you have already been compensated for the staffing. So just two questions on that. When you say we have already been compensated, is that all private long-term care facilities?
We were all given an extra $15 a day per resident for staffing, PPEs if we needed it, and anything else. In our company, I can speak to it a bit, and I'm sure it's the same in other companies. There were extra training costs and overtime costs to make sure we had our full ratio of staffing.
Okay. And is there any commitment to additional supports for staffing moving forward, considering we are still in the pandemic?
Yes, if needed. The minister has put it this way: if you're financially harmed by this, come and see me. And they would develop a program that would work for all of us, be the same. But we've had probably up to 8, I would say, phone calls between our association and the minister and deputy minister. And there may be a need for some extra money, but nobody's pushing me real hard on that right now. It would be if what became an extra cost was the visitations and making sure that we had greeters and people and cleaners and that could cover visitation.
And one other question I really wanted to ask about staffing, and I asked this during the sitting as well, so I'm just getting some clarity on paid sick days for long-term care staff. Do all staff in long-term care have access to paid sick days in private facilities?
No. I don't know, some of the other homes have. We have in one home and we have part of them in another home. And we're trying to figure out how to do that, and we've given them loyalty days and home days where they don't have sick days. One of the real problems in staffing in a long-term care facility, public or private, is somebody phoning you at 6:30 in the morning and saying, I won't be in for my 7 o'clock shift, and you have to replace them, and that's difficult. So what we're trying to do, and sometimes they're not really sick, but they have a doctor's appointment, and the only way they can get a day off is claim sick days. And we're trying to change that so they can tell us a few days ahead that they're going to do that. But sick days we're unionized, and sick days always come up, and one home has better sick days than the other, and it's kind of what the workers demand.
Yeah, just one more on
Quick
this.
one.
Okay.
Heath and Hannah.
Just to say that it's always important, of course, that workers should have access to paid sick days, I believe. But in this particular case with COVID, the last thing we want is for any worker to come into a long-term care facility if they're feeling ill, right? And let's be honest, I've never worked in long-term care. I used to be a child and youth worker working in residential care, and if you had the sniffles, you'd probably still come into work, largely because of the problem you're saying that you might be putting someone else in a difficult position if it's 6:30 in the morning, and that if you don't show up, then that worker that's on now or at that time has to stay for the next shift, which is hard.
Yes.
But the reality is, though, during COVID, we don't want anybody coming in with
Absolutely.
any sort of. So this is not just to sort of, I don't want to point fingers, I'm just pointing out there's an issue here in that we want to protect the residents and staff of long-term care during COVID. Was there ever any discussions with government about some additional support, particularly around making sure that staff have paid long-term care at least during this public health crisis?
No. And not from the staff in particular. I'll tell you what happens. You'll remember that Whisperwood Villa had a scare with one of our workers getting COVID. And it never got into the home for a couple of reasons. One is when you come to work, you're met by someone who takes your temperature and checks you, all the questions. Have you been out of the province? Have you been out of the bubble, and all of that. The other thing is everybody wears a mask and that sort of thing. So we haven't had discussions because that hasn't been a problem. But I'll just tell you, when we had our scare, we give our workers $100 each for that week for showing up. But we also make it very clear, we don't want you showing up if you're ill. And if that became a problem, there's things that we would do. we've got some things in mind. We would look after them in terms of our workers. But sick days are, it's not only the problem of the sick days, it's the problem of staffing. They're part of that matrix, you know, that I'm talking about. But one home has 14 sick days a year. And one has five or six.
Thank you. Heath, did you?
Yeah.
Perfect.
Just a couple of things. It is interesting, Bob, to hear the variance between the mental health beds at the QEH and you possibly opening up for the long-term care. It's been a big issue for us in this committee, and we're hearing kind of variances of what transpired over even from Dr. Kaiser in the paper yesterday to what she actually said in here a week before. So it's good to hear that your association offered to move those patients, because I think it's extremely important that those hospital beds stay there. But with the federal government doing a lot of transfers, and we're seeing all the gaps in COVID, and especially with the federal government saying the changes that are coming across the country as far as nursing homes, like where is that at with them? Is this just talk? I mean, we've seen resilience funding yesterday announced for schools to speed things up. Could you be a part of that resilience and funding for expanding your buildings to house more long-term care patients or more patients with dementia, which is a huge issue, as you said?
I have to be careful with this answer because I have certain opinions. I've worked in the Ontario Civil Service. I've worked in the PEI Civil Service. Let me tell you, Ontario is the worst civil service in Canada, second only to the federal. And PEI's amongst the best because of the size of our operation and that sort of thing. And not everybody agrees with me on that, but that's my feeling. The federal government announced 2 months ago infrastructure money. The last I talked to the minister in PEI, he hadn't been informed about it yet. My stand is, and this is a personal stand, so, is that the best thing that the federal government can do is get money to the provinces. They have the taxation ability. The provinces have the much better capacity to ensure that programs happen, in my view again. But the money from the federal government is going to be helpful. No province is going to be able to live with whatever deficit they've rung up, 170 plus million for PEI. That's going to be difficult to overcome over the next little while. But the federal government should focus on letting the provinces deal. I think if they sent the money for infrastructure funding to PEI, even if you were Minister of Finance, Heath, we would get it out pretty quick. We would make sure it's done right. And you were a good Minister of Finance, by the way.
Strike that from the record.
And a good Cornwall boy.
No, and the other thing, on the licensing aspect of the nursing home beds, I mean, when we go under an emergency, what's it called? I think it's lack of a better word, emergency response, or when Dr. Heather Morrison claims that we're under an emergency. Thank you, public health emergency. Would that not justify saying we need more long-term care beds in these facilities and we need them now? And when you said 10,000 or whatever, as you know, that's peanuts. I'm wondering, like, there doesn't seem to be a balance here, because I think
the problem with being in government and allocating long-term care beds is it's hard to get rid of them once the problem is over. I think there should have been a way, and there still should be, a way of allocating beds that are temporary. And Mr. Operator, you're going to lose those beds 6 months after the pandemic is over. That's probably what should happen. But I think that's the problem of just allocating beds. As you know, government policies that you bring in are hard to pull back.
Heath?
And again, it comes back to the, about 100 on the waiting list, and I know, and I'll say this publicly, that I was fighting for 150 beds when we did 100, and there's a need there. But I also will say that it's extremely important and good to hear you talking about dementia, because I hear it all the time. I've seen families and husbands almost destroyed looking after their wives for too long before they moved them into a facility. And two families in particular that I grew up with. And so it is extremely important. So that's all.
Tears families apart. And so on the one hand, you have to think of the resident or the person with dementia. On the other hand, you have to think of the family trying to deal with it. It's another part of the matrix.
So just to recap, I asked the last presenters the same thing, and I would normally ask you to, we're doing a report to the Legislative Assembly in a month's time. This is a crucial issue. Can you go back and potentially write down your top 5 or 6 things that you need that we weren't able to address, or we talked about it, like dementia would be the #1 issue, shortage of workers, mental health capacity. Those we don't have time for today because we have another group in.
Yes.
But we will make sure that this committee does a strong report to the Legislative Assembly on the words that you've spoken.
Your next one is Wayne's son. If he talks as much as Wayne, I might as well carry on for half an hour. You're supposed to help me.
Thank you for coming in. This is a topic that we have to talk about more frequently. So
We are available, and we are citizens of PEI, and we happen to be owners at the same time. And anything we can do to help PEI has always been in our interest.
thank you. Thank you very much. Okay, we're back after that break, and thanks for your patience out there. And And so this is our last presenter, and what I will do is I'll pass it over to you, and what we'll do is we'll let you present, and then we'll ask some questions at the end, and we'll have a great discussion there. So I'll pass it over to you. You can make an introduction for the answer.
Fantastic. Thank you. Thank you, Chairman McNeely. Thank you for inviting me here today, to you and to all the committee members for this opportunity to speak. Of course, my name's David McMillan. I'm owner of Home Instead Senior Care here in Charlottetown. It's a franchise of over 1,000 franchises worldwide. Approximately 45 here in Canada. And we've been in operation for the past 10 years. Just bear with me. This isn't my comfort zone. Although I was a teacher for 10 years, I'm still not good speaking in front of my peers, I guess I could say. So as I was asked to speak on best practices in home care, identifying some gaps that have developed in the past 6 months with COVID during this pandemic, and to give some of my thoughts on the standard of care within the province. So I'll start with best practices, and a lot of the things, I was here for the Medivh Blue Cross presentation, watched it outside on the television, and as well Bob and I'm not going to say Wayne's presentation because Wayne didn't speak, but you may hear a lot of similar themes come from what I have to say. So first and foremost, for best practices, individuals want, they need, and they deserve the right service at the right time and in the right place, okay? And most people will say that the right place is at home for them when we're talking about aging. So for me, there are a number of things that stand out. First, it's public education. So people are lost. They don't know where to turn. They don't know what groups to go to. Even when people make calls to provincial agencies, that they all sometimes don't know where to point and give people direction. We often find we are the providers of information and helping guide people through the healthcare system. So clear and complete information about people's potential health journey needs to be in the forefront. It needs to include all services, nonprofit, public and private. And there was years ago a group that was really focusing on this, and it just seems to have may have lost some of the wind beneath its sails for one reason or another. But this was done with Dr. Michael Corman and a study he did. The second thing is appropriate assessment. Prince Edward Island is I believe, the only province not using the inter-eye assessment tool. They're using a homemade assessment tool that has been in place for probably 30 plus years. And what it's doing is pushing people to community care facilities and nursing home facilities before their time. With the right care in place, they can be going home. And it should be, in my opinion, home first philosophy. Thirdly, individualized services. So services need to be tailored to the individual. You can't look at people as a broad group. I know this takes a lot of work to do such a thing, but everyone has unique needs and goals. It should not be a fixed list of services that's provided. So presently you may have, and I've been barking up the tree of government for close to 10 years now about a few things in particular. And one would be, for instance, a resident care, or a home support worker going in to provide respite care to an individual. The individual may, or the family of that individual could really benefit from extra supports. Well, we give them the respite time for the family to go and do the things they need to do before coming back and being with their loved one. But the home support worker from the province does not do anything other than companionship care in those respite cases. And so they may need a little more than that. They may need assistance with anything from meal prep to laundry to the list is endless of things that could be done to support that individual and their family in the home. But a worker would just be there in a companionship role. And sometimes there'd be obviously some personal care take place. Whereas a private agency does not have that. We have a more flexible way of approaching our clients with respect to supporting them wherever the support is needed. Again, I think these individualized services need to include specialized services, caregivers, formal and informal, and a healthcare team. They all need to be part of that in creating what it is the individual needs support with. Innovation should be used when and where appropriate. And today, you heard from Medivh or Island EMS that the technology is there. Homestead is partnered with GrandPad, and we are presently, that's a large tech company in the United States. We're presently launching within our Canadian franchises that as an option as well. Reduces the number of visits caregivers have to make to the home. So that's another an area where Homestead is moving towards. I should also mention, I'm here, I guess, wearing two hats. We established with Bayshore and We Care, the Home Care Association of Prince Edward Island a number of years ago. However, due to changes, I would be the lone member at present. We Care does not provide service in the home care field anymore other than foot care and physio. They've been bought by the CBI, Canadian Back Institute, and they have changed their focus. So they're non-existent. Just to touch on gaps, we have a navigator program where the province assists people. It's a great step. It's the right step, I think. However, those people need the proper information. When they're still giving 85-year-old women who are being discharged from hospital lists with We Care still on it as a number to call, we have an issue. This is recent. We Care hasn't been in existence in home care in 3 years. Another gap is when, it's a major gap in my opinion, is when social workers or those in charge of discharging individuals are giving clients, once they're discharged, the list of providers if they're not going to use provincial home care. And those lists of providers include individual names of people across PEI with no checks or balances in place. It's left for the individual to call and try to arrange service for themselves. Homestead and Bayshore are on that list. We're reputable companies who provide training, insurance, workers' compensation. The list is endless of what we do for our employees. And then those individuals who are on that list may not even have a criminal background check. Other individuals, for instance. They would most likely not be paying taxes. because it's really a promotion of an underground economy. It's also very risky to allow individuals into the home who do not have insurance or workers' compensation either. So I think there needs to be some standards put in place and regulations where reputable organizations such as Homestead, Bayshore, Medivh, Island Ems and there are a couple of other smaller, I'll say mom and pop organizations out there that need, once they show that they are paying insurance, paying their taxes, providing training, meeting all their standards, then those smaller groups should be allowed to participate in providing the care as well. Something that really I feel needs to happen is providing home care workers with enhanced training. As Homestead provides our own training, many of our caregivers come to us with RCW training. However, many don't. They come with life experience. We have individuals who, it takes a real special person to be a caregiver, and they go above and beyond in all these situations, and we've seen it especially in the last 6 months. But to enable to retain workers and actually give them a prospect of employment and future employment, like a career, they need to have training that will hopefully enable them to have a better and higher salary. And lastly, and again, these are what I'm talking about here: public education, appropriate assessments, individualized services, and providing home care workers with advanced training. These are all best practices, and these are all things that are taking place across the world. Lastly, for best practice, there has to be incentives for people to use home care. The way the system is presently set up with respect to community care, long-term care, and home care, it's an uneven playing field. There are subsidies out there for people who are going into nursing homes. There aren't subsidies for home care. Provincially, people are receiving a service free of charge when they use provincial home care, but then when they go to a private agency, they're being asked to pay. There is no subsidies that I'm aware of in the home care industry. So the clients who use home care should not have to be paying extra. In my opinion, there should be an incentive program for those who are paying for home care, and whether that be in some sort of family tax rebate or a caregiver credit for those who take time away from their job, as in a family caregiver, to help assist their loved one. There are a number of different programs out there worldwide that are presently being used. So after mentioning those positive things that are taking place in the system, and some of those things are occurring here, but maybe need to be fine-tuned. There are a number of gaps, but before I talk about the gaps specifically around COVID, there are those gaps in the sector. And again, you've heard a lot of them here today already. Workforce availability is a huge issue. We actually are providing caregivers to the nursing homes at present, and we have for the last number of years as an agency, because they can't get staff. And now we're running into the same issue. We can't get staff. So we're sort of at a standstill of approximately 70 caregivers province-wide. which during COVID times dropped down to about 25. We had well over 50% of our business pretty much wiped away. 10% is still gone because we're not allowed into nursing homes to provide the care. Sorry, I should specify that we provide staffing for 2 large groups here on PEI, but we also provide care in those homes separately from the staffing, care that is purchased by families that feel that maybe service may not be what they anticipated it would be, and it may not be at any fault of the facility or the nursing home, but they're in both provincial and private homes that we go into. Our caregivers go in, they may assist with feeding, they may assist with behaviors in lockdown units for Alzheimer's and dementia. There's many different reasons why our caregivers go into nursing homes to provide care. At present, we can't do that. Unless our caregiver is specifically going to that one home without going anywhere else, because that is a present public health recommendation, okay? We also have major discrepancy in wages between provincial and private providers. When a RCW with the province is being paid $23 an hour, and then you have a private provider, and I can only pay $13 or $14 an hour. I definitely understand why we're having challenges in people coming into the industry. The province, and I'm surprised Bob didn't mention this, but they get a lot of the caregivers, RCWs, PSWs that are coming out of Holland College, Academy of Learning. I think there's close to 100% hire rate, and I would think that probably 90% of them are hired by the provincial government at that rate of $23 an hour, with their overheads exceeding $30 an hour. Our service costs $25 to $30 an hour. So how can I pay my employees a respectable wage? I can't. So and Bob would be in the same boat in paying his caregivers $15 or $16 an hour at his facilities. We can't compete. We're in competition on 2 fronts with the province. 1 is with staffing, and 2 is with services. And from a home care perspective, whenever the province is providing a service free of charge, I feel it needs to be addressed. Different client costs and supports when considering long-term care. I touched on this about with means testing, financial questions with long-term care and community care. Two different ways of approaching services, and home care does not have any testing whatsoever. You can self-refer to home care. You can pick up the phone. Not many people know that, but you can pick up the phone and call Provincial Home Care at any of their 5 offices across the province and self-refer. A nurse will come out to your home and assess you and determine whether they will come in and provide the service. Usually what will happen, they will only be able to provide a portion of what is actually needed, and that's when we get called. And we are often working hand in hand with the province in a home with someone. I guess also in that area, a major issue or gap that has always been there again is just including agencies like myself in talks, or if there's going to be funding given out, that it be an open and transparent way of doing it. instead of finding out in the news that certain organizations have received funding to provide certain services. There's also a major underutilization of private insurance in the home care industry. When people are being discharged from hospitals, although social workers and discharge planners know questions need to be asked around things like private insurance or are you a veteran? For example, the federal government would pay for services. They're still going out and into the provincial government system. So, and it has nothing to do with quality of care. Quality of care on the private side, many would argue, is higher and better. It's the existence of our organization. If we do not provide quality care, we will not be providing services. So that argument doesn't stand. We're both there with quality. It needs to be looked at whenever people are going into, it's in a way for the province to potentially save small amounts of money when individuals go into the system that if they have private insurance or if they're a veteran, and these are just two examples, or eligible for any other programming, that they go down that path and use businesses or private businesses instead of, backlogging the home care system. People are returning home and having to wait 2 weeks before a home care worker goes in to provide service. They could have called us and we could have provided that service. I don't mean to say this nonchalantly. It doesn't matter who's providing the service as long as it's the right service and it's quality provider. So those are things that personally need to be looked at. I heard a member here talk about groups working in silos. Again, that is a major gap and constraint in the whole system. Communication and those groups work. I know there was a group a number of years ago, the Health Sector Council, that had brought private, public, and nonprofits all together. Seemed to be opening a lot of doors, and people were really excited and understanding what everyone in the healthcare field was doing. And I understand funding was cut for that. So that sort of, again, is we get so far and these things just are at a standstill. They drop off, and we don't see them all through to fruition. Medically discharged clients, because once they're medically discharged, they're no longer a patient. I provided a pilot to the former government that may have assisted with that. I see it involving specialized services, occupational therapists, physiotherapists, social workers to a greater extent. There are dementia clients within the system, and there probably is one or two in this group of 25 at the Queen Elizabeth Hospital that could go home. They need to go home with supports. They're staying in the hospital, and I'll throw a number of, let's say, $1,500 a day when you take into consideration the lights and everything else involved with costs, and we can paper and toilet paper and the staffing. We can provide that service at home if the home is safe, retrofitted possibly, special locks on doors, grab bars, etc. We can provide 24-hour care for half of that cost. We've provided pilot to the former government with respect to that before. Unfortunately, it didn't go anywhere. So many of these topics, they've been around for years, but they've been just increased immensely with respect to COVID. Workforce availability, I really and truly think we've already are seeing the start of it, but workforce availability is one of the major issues that we're seeing. Staffing is getting more difficult. The CERB program that was provided by the federal government was a huge issue. We would have lost a dozen employees who just refused to work, wanted to just, fear may be a reason, there's anxiety, they're all reasonable. However, during COVID, numerous people would just go on that program, and some still have not returned to work. So that was a major issue. However, the essential workers program provided by the province was extremely beneficial, because it then saw those people who were working pick up extra work in order to be qualified for the essential workers program. A $1,000 bonus goes a long way, especially when you're only getting $13, $14 an hour and you're working in a vulnerable sector during a pandemic. I feel whether it be a subsidy with certain criteria for staff they need to make with respect to training to bring them up to par with their provincial counterparts would be something to look at. I already spoke on the wages and essential workers and medically discharged individuals. Again, it goes down to the right care at the right time in the right place. A few other things that have really came to the forefront during the pandemic are things like lack of technology that's being used. And we're behind the 8 ball on that as well, with our tech advances were unfortunately put on hold before COVID, and then we weren't able during COVID to introduce that because of the staffing challenges we've been having. Homestead as well, just to add, is moving in not only home support as a home support provider, but we are also moving in the area of a medical provider, RNs and LPNs. And again, that has been put on hold due to COVID. So organizations such as Medivh expanding, Homestead expanding, Bayshore, which is now coming back to provide home care support. They took a little bit of a break, and will be expanding services. You have those 3 great organizations, reputable organizations that are here on PEI trying to provide services. We also had an area that presented itself as protective equipment for staff. It's something you don't think about until you get hit, a pandemic comes. The province, I think, although we did not have to use the program, I think they did a really good job, and they're staying on top of the amount of protective equipment that's in Prince Edward Island. We do a weekly submission to a staff member with health, I believe with Health PEI, of what we have on stock for masks, for instance, hand sanitizer, gloves. And that way, if an organization or nursing home ever runs into problems, and Bob alluded to it as well, that I think they have used it, we can contact that agency, and they have a central location where they can hand out equipment if you need it. We did see it was a challenge back in April, May, June to purchase any masks, hand sanitizer, gloves, etc. However, since that time, the vendors have been able to get stock. They're selling it, unfortunately, at a higher cost. So these are all things that come into play. I guess internally there's been a few challenges, and I guess that's just with us following public health guidelines. with who is deemed essential for receiving service. With COVID presence, some of the provincial home care clientele were deemed non-essential. Therefore, families were then left to provide the care. We would then get the call to come in, but we're following public health guidelines. We can't go in and provide service if we feel it's non-essential. Well, what is non-essential? Well, you could, that's an argument, and you could go down a list of things again, but we just felt there it really put a lot of pressure on us and on families during this time. We also had to be very careful on scheduling and staffing. We really tried to consolidate who caregivers were going in with, that they weren't going into multiple, a situation, for instance, where if someone has 8 hours a day of service, 7 days a week, you may need 2 or 3, maybe 4 caregivers in that situation to provide the care. It's not easy to consolidate that down to 1 or 2 caregivers because you're trying to eliminate the spread of COVID. But that is an area with extra time and cost with respect to scheduling and things like that became a real challenge. And lastly, I'm sure every business has had this issue, but just trying to navigate provincial and federal funding, and this isn't specific to home care, that's for sure, it's every business, but the amount of cost and time that is put in by each business, I'm sure, in trying to navigate supports for not only clients, but for the business itself. I do, again, the emergency wage subsidy, QC, Canadian Emergency Wage Subsidy, is instrumental in I think, a lot of the businesses being able to operate and continuing on. I know it certainly is in our case. And again, the essential worker subsidy was something that I think was instrumental in us keeping staff, because without those two support mechanisms, a lot of businesses, again, not specific to home care, but wouldn't be in operation. Standards of care. So it's hard to measure. We usually, it's through just communication with family and clients. You find out if you're doing a good job. To my knowledge, there is not a tool that measures the standard of care on PEI with respect to home care. Again, families share stories. You make improvements. It's very important. Communication is the key. Homestead sends surveys upon completion of service and during service, and that is how we get our feedback and make improvements. So I guess the question would be for provincial home care and what they do with respect to measuring their standard of care. Ideally, goals would be set in a care plan, and if you reach those goals, you've met your standards. And those are something that isn't always being done. However, it probably could be.
Great. I'm sure we'll pick up, if you've forgotten anything, like the committee will definitely probably get it in there on our questions. But
certainly, yeah, I'm open to questions.
Excellent. So we'll start with Hannibal.
Thank you, Chair. And there's a couple of things. One of them is a disclaimer that I have a family member who's actually employed by Home Instead, so that does not mean that I will be easier or harder on you, but and then the other thing, Chair, is I do apologise, but I am going to have to go. I have to get to another space for 4 o'clock. So I just have 3 questions, and they're all kind of fact-checky questions. You mentioned an assessment tool that the province, this is the only province that is not using Interact?
Sorry?
Interact, correct?
Yes.
I do believe we use it for accessibility, but we don't use it for any other programming.
Okay.
Sorry, I didn't mean to.
STAS is the, I'm not sure what the acronym stands for, but the present testing assessment tool being used.
So the testing tool we're using currently is proprietary, but every other province is using a standardized, up-to-date.
I'm pretty sure that's what's taking place.
That's what I thought, but I just, yeah, okay. The other question I have is, what I'm hearing is that this is not a regulated profession.
I'm sorry?
This is not a regulated, they don't appear to be.
No regulation whatsoever.
Right.
We set our own, we have our own standards. Yeah.
So we have, the province is offering home care free of charge in this space, and then there is an additional space that you're in providing a fee-based private care, and they overlap in some places?
They do overlap in some cases, yes, yeah. And I guess there is one where there, yeah, sorry, I'll just let you.
I'm sorry, I am absolutely, I'm speechless, which doesn't ever happen, very, very rare. I cannot imagine how we can have a profession that is meant to be taking care of some of our most vulnerable people, and it is not regulated, or like the idea that there's a list being given out with individuals on it. And another disclaimer is I worked in the past on a project around elder abuse, and it is a real and serious thing, and one of those things is about the security of people who are vulnerable when they are, when somebody has access to them that is not supervised. And I'm sorry, I'm horrified. So I'm really shocked, because this is a critical piece of our healthcare delivery. We've talked so much about the aspect of care in the home is how we can have a more respectful and secure and dignified way for people to be able to age in place. It's a pillar, but it's not regulated, or assessed appropriately, or have any standards of care that are required other than those that you bring to the profession as a professional. Okay, that's...
Now, I've been told in the past by ministers, MLAs, high-level management, that this particular list that is given out is needed, and legally they have done their checks and balances, that it's okay for them to continue on in this front. So that's what I'm told as a provider.
Anna?
My 13-year-old has to have a course and a license to be a babysitter. And she gets paid more an hour. Yeah, okay. So that's kind of all I've got to say about that, Chair. I'm going to wrap it there. Thank you so much for the presentation today. I do have other questions for you that I will ask another time, because I'm going to get my stuff and go. Thank you.
Thank you. Thanks. Trish?
Thank you, Chair. So, David, you mentioned that staff at home and instead make $13 an hour.
Yeah, between 13 and 15 as a caregiver.
Okay, as a caregiver. Oh, what are the other types of jobs that?
Well, they would be within the office,
Okay.
schedulers, training and retention with respect to staff, with those caregivers.
Okay, but anyone working with clients would be in the caregiver role. Okay. And how many of those caregivers work full-time?
They're all casual employees due to the fact that the nature of the business. We're set up differently than the province is set up, where they have full-time staff that go out, or they're given their list of clientele to go visit, and they have from 9 a.m. to 4 p.m. to visit those 6 individuals or what have you. I don't believe the province uses any technology to monitor where those individuals are if certain people do not require service that day. So what does that home support worker do if they arrive at Mr. Smith's house and he is at an appointment and they have an hour before they're still being paid? So what we do, we are client specific. It's client needs. The client is who, they make the decision on when they get the service. For the most part, we arrive and provide those services. I can't answer off the top of my head full-time employees. We have between 60 and 70 employees. We provide, on average, before COVID, we were providing around over 4,000 hours of care a month. We're cut in half since COVID has, the pandemic has been present. So that's where we're left.
Trish?
And as you probably heard me ask the previous presenters, I asked about sick days. Now, of course, we've seen the issue with long-term care across the country and what that can happen when person comes in who has
Sure.
COVID. It can spread quickly. This is not the same situation, but it is a situation where we're working with elderly, vulnerable populations. And of course, we don't want even one person to be exposed, or necessarily a vulnerable senior. So
Right.
do your employees have access to paid sick days?
Not as a casual employee.
Okay.
They do not.
Right.
So what we do, if someone calls in sick before COVID, we would just work on having that shift filled by another caregiver. Again, client is in control, whether it be a family member or the client, and a lot of times they may request that service take place another day. I should specify, Homestead at present is a provider of non-medical care. So if we may have had a caregiver in the day before and provided 2 or 3 meals, the individual is going to be okay in this circumstance. Sorry, can you repeat what your question was there?
I was asking about paid sick days.
Yeah, so no, there is none for the casual employee. However, during COVID, because of the queues, anyone who called in or that was sick and couldn't provide a service or couldn't go to work, or if an individual couldn't go and be we couldn't go into a shift because of the threat or fear of COVID, which has happened. I know Bob had mentioned the scare at Whisperwood. Well, an individual would call and say, so-and-so got tested for COVID, they won't get their results. It's my husband. They live with me. I can't go to work tomorrow. So we would fill the shift with someone else, and we'd use the CEWS program to pay them their wage.
Sorry,
Trish?
maybe I'm not sure.
Canadian Emergency Wage Subsidy.
Okay, sorry, I haven't heard it.
Yeah,
called
that's
CEWS
okay.
before.
Yeah.
Okay, gotcha.
So now we can't continue to do that endlessly, but for specific cases where a staff member or caregiver couldn't go specifically because someone was being tested for COVID, we paid them for their shifts by using the CEWS.
Just to clarify then, so
Trish?
that was only if someone, either the person themselves or in their household, was being tested for COVID. So let's say,
COVID specific.
okay, what if someone
'Cause
has a
that's
sore
the-
throat or, fever or whatever? No, okay,
They're a casual employee, so they don't have
yeah.
any benefits.
okay.
Trish?
Okay, thank you, Chair. So I'll just, I guess, ask one more question. Some of what you're saying, I think, I definitely agree with, that we do need to put more investment in home care. Absolutely. I think that what I'm hearing is that the stays in our long-term care facilities are, in many cases, far longer than they need to be if we
we're the
had
highest in the
sufficient
country.
long-term care, sufficient home care supports. Yeah, highest in the country. That is incredibly concerning.
Yeah.
If I will be completely honest, what I'm concerned about is, I'm not comfortable with this, is supporting government, providing funding for a business model where workers are casual, paid below a
Yeah.
living wage,
Yeah.
and don't have access to paid sick days. and I realize that that's quite harsh, but I just want to be completely honest that to me is from my position to advocate for government to invest in this type of home care, private home care model is not something that I would support. Now, I don't know if your business model can change in partnership with government or what might be possible, but as stands, that doesn't seem like a good solution to me, and not something I'm comfortable with. And I will just add that another thing you said that these workers are very special and that they do important work. I agree with you absolutely. I think it takes a special person to do this work.
I couldn't agree with you more on everything you're saying.
Yeah. Okay.
I would pay my caregivers $23 an hour, just like the province, if I had the ability and capacity to do that. But when my service only is $25, there's only certain amount of room and margins to be able to pay someone a respectable wage.
Yeah.
Can't do it.
And I'll just quickly say, and I understand that from a business standpoint, standalone, I hear what you're saying, but in terms of me supporting government, supporting a private and business model like that, I couldn't. That's all I will say. Thank you.
Thank you. Heath?
David, what about other provinces? Homesteads across the country. So what's the difference? Is there any other Atlantic provinces, say, for example, that have the regulations, the standards, the subsidies, or what have you?
Not in Atlantic Canada that I'm aware of. I know in Nova Scotia in the past, I'll be quite honest, for the past 2 years, I've pretty much just been focusing on my business. I haven't been involved a lot with the province, although probably 2012 through 2016, a lot of my time and energy went into that. However, I think in Nova Scotia, for instance, they would, anyone that was on a waiting list for home care, they would share that information with the individual, that these other organizations are available for you to use. I know in some provinces they actually feed agencies. I know in Ontario, the LIN, for instance, they would provide the clients to these other agencies.
Heath?
I did have a question on going into nursing homes, but obviously you answered that and you're actually doing it, so that's good. But just on the underground economy, if that's what we want to call it, we talk about wages and, trying to compete. Well, it's pretty hard to compete. You're in the middle and you have a huge underground economy and then you have a government above you that's going the other direction. So how do you overcome that? Like, who licenses you, I guess, maybe start with that. No one licenses you at all. Wow, that's interesting. And the council that you talked about that dissolved or just kind of went away, is there some sort of avenue for you to kind of recreate that and get, like we've had long-term care issues here with mental health issues, we've had paramedicine in here that's actually doing what you're doing in some regards, maybe a little more extensive. There's such an overlap, and I know you and I had this conversation years ago about when you were first starting out, I think. There's such an overlap, but no one seems to be able to bring everybody together to say, how can we make health PEI better utilizing all these different avenues that we have at our beck and call.
There's been moments in the recent history where that has happened, where groups have come together. But as you know, those reports, whether it be Michael Corman's or Corpus Sanchez or they get shelved. The Health Sector Council, it seemed to be doing a good job at bringing all those three pillars together: the public, the private, the nonprofits. But again, the wind sort of left those sails, and that's not being utilized anymore, obviously.
Okay, perfect. What we're talking about today is a crisis, and you're and the only option when you talk about 4,000 hours before COVID, now you're at 2,000 hours. How is that affecting you? And I look at, playing off of what Trish said, the only option you'd have is to raise prices, and
You can't.
the seniors are going to be the ones who suffer.
Yeah, there's no room to raise prices in the, you know, we're the lowest in the country with respect to prices. You go to Ontario to have a home support worker go in and provide a bath for an aging loved one, you're paying well over $30 an hour. And those individuals in Alberta and in Ontario are only being paid $15 an hour. The industry is broken with respect to wages. And I couldn't agree more with you.
Yeah. So here we are in the standing committee. We're hearing a lot about long-term care. We're wrapping up for the day. What's 2 or 3 things that you'd want to leave with us that the province could do to support not long-term care, but in-home care more efficiently?
Well, again, I think with respect to, it's hard for me to come at this from a business perspective and also a healthcare perspective. People have a real hard time grasping how can you be in those 2 things at the same time. But yeah, no, I think needs, again, those 3 things that I talked about, proper assessment tools, the right care at the right time, by the right people. And again, it doesn't have to be specifically a public paid employee to provide that service. And then I think, as I talked about those wages and the workers, I know where can you get those individuals a higher wage there, so we don't end up in a crisis, because we're definitely at the start of it. And I'm not sure what the answers are for that. Again, it's appropriate assessments and individualized service is the way I see it as being the proper way to go in that area.
Just have one more question from Ola.
Okay.
Thank you. As we heard earlier, in terms of nursing home spaces, there is a model where the private and the public work side by side, and as we heard, the private sector provides more or less the same service at a net savings to the province. In your case, it seems to me that couldn't that be used as a model, that if the province gave the choice of which service they would choose, whether private or public, was both being supported at the same rate as we're currently paying for the public service, that you would be able to both compete and pay a decent salary?
And we've made those suggestions in the past. They didn't catch any interest for whatever reason until Medivh received a contract or a tender in recent years, and they shared a lot of it with you today. Yeah, so.
Right. Okay. Thank you very much. It was a very great presentation, and appreciate your time today.
And feel free to reach out with any questions if you have anything further.
Perfect. Thank you very much.
Thanks.
We'll take we'll just keep going. We'll wrap this up. He got out of here pretty quick. Did I hit my gavel?
I just want to make sure it's back on.
Do we?
They're fine. Here,
Yeah.
just hit it again, maybe.
Oh. Okay. We're back. Just to wrap up, we're moving on to number 4, the discussion of the Human Rights Commissioner appointment. I know there's a couple of committee members who are subbing in. I don't know if that would affect. We'll pass it over to the clerk for a quick update on that.
Yes. So underneath the agendas there's an ad that could go out to the newspapers on the island. Just want to confirm that we're good to send that out. And then the one on the back of that, or depending on the side you're looking at, is the one that would go out to social media. So once we confirm that, I will send it to the members who aren't here as well, although we have to confirm it today to get it in for Saturday's paper. So it'll go out on Saturday with the Guardian and the Journal, and then the 3 weekly papers on Wednesday. And if the committee's okay with the deadline of the 13th, then we can go ahead.
Is this one we used in the past? Similar? Or is it?
Yeah.
Yeah, so, okay, all right, so just make sure that the other committee members know.
Yeah, I'll send it.
And then we'll approve it here today and leave it to the clerk. We're not gonna talk about actually, we'll move into number 5, new business. We're not gonna talk about the Brooks Roach for time purposes today, but does anybody have any new business at this time?
Maybe just get everybody's feeling on the, I know the presentation that Dr. Kaiser came in and did, and then when you read the CBC article, it's kind of threw me for a loop, saying it's almost the opposite of what we heard. So we heard from Canadian Mental Health, and then we heard from Dr. Heather Kaiser, and then you read in the CBC that they're in almost panic mode. So I'm just kind of curious what everybody else's thoughts are on that, or is there anything we should be kind of like worried about here? Or?
Yeah, Trish?
Thank you, Chair. Well, I believe, Dr. Kaiser did say in her presentation that they need to reopen Unit 9 and that was something they expected to have happen soon, but she wasn't able to provide at that time any details on how that would happen. And if you remember, I asked that and got a quick response that they didn't have that info. That I think is the crux of the issue here, is that there's no plan for how to move the patients that are currently in Unit 9 to a safe space. And I think that it was interesting to hear today that, private long-term care facilities have put forward proposals that would solve that problem. And this problem needs to be solved very quickly. So I'm not sure I would say it was so different, but perhaps that since the presentation, if Dr. Kaiser has not been provided with any information still, she's probably becoming quite worried, and I can understand why, that Unit 9 will not open on time. So that was my sense of reading that article. Did you have suggestions of what else we might do as a committee on this piece?
I think after hearing Bob Nutbrown today saying that they offered 16, I think he said,
16 to 20, and he said, I thought he said more than one provider put in that proposal as well, right?
I think he said that he did.
Sydney?
Sorry, Chair. I think he said he did, but he was unsure if others had as well. In his role as the chair of that group, he hadn't heard yet, but wouldn't be surprised if others had.
Okay. Sure.
Trish?
Even the one proposal should solve this immediate issue, right? We have 19 patients according to that article, so they should be able to make that work. So, perhaps, I don't know if I can put forward a motion that the committee could write to the minister to find out, if he has considered those proposals and what the plans are to move the patients safely out of Unit 9, patients with dementia. Does that, something along those lines, seem like an appropriate next step?
Yeah, I'd like to see, I think it's time that if we can potentially talk about getting the minister or deputy minister in to talk about the things that we talked about today and maybe that situation, it might be a good opportunity. So,
I think that's a good idea, and I also would like some clarity on something that was mentioned by the minister during the sitting about the quality of care provided to acute psychiatric care patients that had been moved to the Hillsborough Hospital, saying that it was actually better, and I haven't heard any actual information backing that up. Yeah. So I think that's something we should unpack as a committee at this point. If how are decisions being made about mental health care during COVID, and how are we assessing whether or not care is improved or where the gaps are, particularly with moving to a mostly day, treatment models. So, sorry, go ahead.
Yeah, excellent. So,
So, sorry, just to
Alicia? Yeah,
clarify,
clerk?
we would be asking the minister, deputy minister, about the presentations as a follow-up to these ones, home and long-term care, and also mental health, kind of get one presentation on both.
I think, Keith?
Yeah, I think he's just basically, I don't know to what extent of presentation, I guess that'll have to be for them to resolve, if we ask them to come forward and at least explain kind of this process of what we heard today, because it's kind of convoluting. So we're going around and around here, and we don't seem to be getting anything that's kind of concrete. So I think the presentation could be left up to them, but even to answer some of these questions on the process of, from the time the letter went out a couple of weeks ago, if that's what Bob said, as far as, you know, or before that, I guess it was, but. that's-
Sydney?
Just to clarify, I believe he said that he sent it today after he watched Compass last night.
Which letter?
About providing for the bids.
Sydney? Heath?
I thought he said early, maybe I missed that, but
I thought he said earlier, but we should confirm that.
So,
Sydney?
so there's two things. You're talking about the minister's letter or Bob's letter? Because the
Bob's.
minister had reached out about something, and Bob said it was about potential opening beds, and Bob said that he wasn't sure why he was reaching out for that, but he assumed it was because of Unit 9. And then he said that
2 weeks
Bob
ago.
offered his 16 beds today. He contacted his CEO to send it today after watching the story last night.
He got contacted 2 weeks ago about the beds, yeah.
Yes, yeah, that's what I said.
Yeah.
Yeah, but he couldn't confirm why. Like,
it's-
he just wanted to know what beds were available.
Yeah.
And I would suggest too, if you're going to send a letter to the ministry, you do it quickly. Because I was just reading the story too, and it says that they had hoped to see the psychiatric patients back in Unit 9 by the end of this month. So we should send that letter quickly if we're gonna do it.
Sure, yeah.
Because it's gonna be done in less than 9 days.
Well, they hope it's
Trish?
gonna be done. That's not very definitive language, quite honestly, but anyway.
it seems,
Heath?
it just seems to be a little bit of sense panic even in Dr. Kaiser's comments. That, you know, Sydney, if we're gonna go back into a second pandemic, which I think we likely end up will, or we're starting down that path, then do we need to kind of put a plan of action in place and be clear on exactly if these long-term care facilities can house long-term care patients without moving someone with a mental illness out of Unit 9 at the QEH, then I think that's a good idea, and I think just asking those questions on the process, and then maybe it's just we're hearing from different folks that it's not clear to them or us or whatever, but, I mean, it's not clear, obviously, in my mind anyway.
Yeah. So, clerk?
So this is something the committee has like urgency around. We do have all of our Wednesdays booked, but if they're open to looking at another day to meet, if you want a presentation, as long as you guys are okay with that, I'll start looking at the schedule to see if there's some holes to fit a schedule or a meeting in.
Do you want to, is it going to be a motion, or do you just want to send a letter? Is everybody okay with sending a letter that they would, it's up to you, it's up to the committee. We'd like to maybe see them in before the legislative soon, so we'll give them a few options about coming in, potentially.
Yeah, I think I would agree that it would be a good idea to have them come in. And you know, I'm thinking about what else would we want to get out of that presentation, and I suppose, you know, one of the major questions here is why has it taken so long to reopen Unit 9? How are we prioritizing when things will reopen, particularly around mental health services? So I would like to know that, you know, who is making those decisions and how are we making those decisions? I don't know if we can put that in the letter, but that's what I would like a presentation on, the who and the how of that.
And I would add, the presenter did say that dementia is the #1 issue, and that has forced mental health. So that's important to myself as well. So maybe maybe we'll send that letter off. The clerk will obviously send it to me before, but I think that's what we'll work on that and try to get the minister or deputy in to ask him some questions about that. Sydney?
surgery, and so what was the exact, like, because I remember watching this committee had a presentation on mental health, right? From them, so like I'd say,
Yeah.
be specific, like, to Heath's point, a bit more specific about
Sure.
what's gonna be the plan for the next time this happens. I understand these patients are at the Hillsborough Hospital right now?
Yeah.
These clients, or?
No. Some were there, is my understanding, but some were released home, and we've not had the capacity to admit any new patients who are in need of specialized acute psychiatric care. So for me, I guess it's just building on Heath's question, because in understanding what's going to happen moving forward, we have to understand how government is prioritizing what will and won't be closed when, right? So, and what will reopen first. So that's something we need to understand, in my mind, about what's going to happen moving forward.
It's the whole process. Obviously,
Yeah.
they likely learned from this experience, so enlighten us, basically. Is what
Yeah,
it
and
is.
the long-term care national crisis and how it's affecting us, and it seems to be doing that, so those things. Yeah. Perfect. Okay, is that okay with the committee if we leave it there? No? Okay, so we'll get that letter off immediately and try to get them into C. But other than that, is that it for new business? Thanks for your patience today. Great session. And can I get a motion to adjourn? Trish? Good. Meeting is adjourned.